So pregnancy-related AKI per se is a leading cause of AKI in developing world, but the numbers of pregnancy-related AKI are significantly increasing in the developed world. I'll show you some data. And unlike the CKD cohort which we saw, AKI cohort has very much increase in mortality. Both women, that is the mothers, and also in the fetal. So if you look at the changing landscape or epidemiology of AKI in obstetrics, in the developing world, there is a steep decline in the last 20-25 years from 30% to something like 5%. Whereas in the developed world, there is a significant increase, at least on paper it is around 0.5% today in 2024. The reason for this, developing world got wiser, they legalized abortions, and there may have been improvement in quality of care. Whereas in the developed world, assisted deliveries are increasing, advanced maternal age with diabetes, hypertension, all these are leading to poor outcomes. One of the authors for this paper is Dr. Vijay Verma, who is one of the chairpersons here. This is published in Indian Journal of Nephrology, and they talked of 3 to 7% of all AKI being pregnancy-related AKI. And if you look at the outcomes, once there is AKI in the mother, the maternal mortality is close to 20%, fetal mortality is 22%. This is in stark contrast to what you see a CKD lady developing pregnancy. So this is data again from South India. You look at 365 pregnancies with acute kidney injury. The mean age, this may be very unique to India, 25 is the mean age. Primary 53%. AKI stage 3 was 70%. Maternal death, very similar to what you saw in the other paper, 22% died. This is with pure AKI, whereas fetal death is 59%. Close to 60% of the fetuses died. So this is the importance of AKI and why you should know more about it and do more about it. One of the problems is the definition. We don't know what is the normal creatinine in pregnancy. So what we do is take a baseline. Let us say you know this patient had 0.7. The minute it becomes 1, you label them as AKI. Get a nephrologist in picture. Do all the things so that you don't do further damage to the patient's kidneys. So throughout the different trimesters, the serum creatinine continues to be on the lower side. So identifying pregnancy-related AKI itself is a big problem, but unless you identify, you will not be able to do what is necessary. Classically, we do take them as pre-renal, renal, and post-renal, but what is important is pregnancy-specific disorders which have to be picked up early and corrective measures to be started. Otherwise, the outcomes are, as I showed you, extremely poor. One of the clues will be which time of the pregnancy, first trimester, second or third, that is happening. So taking help of another patient, this lady, 23-year-old, 35 weeks gestation, diagnosed as preeclampsia, referred to us with HB of 8, creatinine of 4.5, severe metabolic acidosis. So the minute there is hypertension after 20 weeks, you will label them or consider preeclampsia. Most of these people, you have to have a DD, and I will just show you, these are the list of tests that you would do to come to conclusion of one of the diagnoses. But please do consider in any of your patients, at least these 9 conditions: preeclampsia, sepsis, TTP, acute fatty liver of pregnancy, any immunological disease which is worsening, and then of course HUS. And these patients, sometimes you may want to biopsy so that you are able to prognosticate and also treat so that the outcomes are extremely good. So if you look at the literature, now we are okay to biopsy these women up to 24 weeks of gestation without any problem. Beyond that, usually we avoid, thinking that the benefit is less and the risk is more, but in advanced pregnancies, you can do a sitting biopsy, unlike the prone biopsies which you do early. Most of the times, these are the lesions you will look at: acute tubular necrosis, TMA, cortical necrosis, glomerulonephritis, or acute interstitial nephritis. The classical lesion of preeclampsia would be endotheliosis. This particular patient underwent LSCS, delivered a live baby. Both were okay, but anuric. So when we did a biopsy, again the problem was ghost glomeruli, as you can see, and patient continued on dialysis, subsequently had a transplant also. Third person, which we are taking the help, anuria, referred with anuria after a emergency LSCS. I will cut short the details. This is a CT scan showing bilateral hydronephrosis. The cystoscopy showed that there was no orifices identified ureteric. So PCN was put bilateral, and this patient became normal renal functions once the kidneys were drained, but this was a bilateral ureteric injury after an emergency LSCS. So when there is absolute anuria, please consider bilateral renal artery thrombosis, severe cortical necrosis, which you already saw, or urinary obstruction. This is data from the city of Hyderabad. Over last 10 years, if you look at 395 pregnancy-related AKI, the commonest cause was preeclampsia, closely followed by sepsis. Whereas if you look at their biopsies, out of 103 biopsies, 25% had patchy cortical necrosis, 23% had diffuse cortical necrosis. So if you are somebody who thinks cortical necrosis is rare, please change your opinion. 50% of people whom the nephrologist biopsies will turn out to be cortical necrosis. So everything that is possible to be done so that they don't get into this stage is extremely important. Let me stop there and we can have some discussion. Thank you very much.